So here we had looked on the hypertension definition, complications, and all that. Today we're going to look at the management of hypertension. How do we manage it? How do we lower hypertension? Now, we have different approaches of management of hypertension, and for us to do it better, you need to have a targeted history, identify the most important associations. The patient has come, he's hypertensive, he has retrosternal pain, he has angina. The patient has a stroke, for example. A patient has a myocardial infarction. These are complications when you look at them in the previous lecture. So check if the patient is asthmatic. Check if the patient has chronic obstructive pulmonary disease, COPD. Check if the patient is having heart failure as a complication of hypertension. Check whether the patient has diabetic or diabetes mellitus, and then check if the patient has polyuria or the patient has nocturia. This night frequent, increased frequency might make tuition. And then for heart failure, we indicate the angiotensin converting enzyme inhibitors. And then for diabetes mellitus, we also give the angiotensin converting enzyme inhibitors. So for beta blockers, for now, we don't give to patients with asthma. But for chronic obstructive pulmonary disease, we can still give beta blockers. So that's very, very high yield. Check the history when the patient has claudication. It might be aggravated by beta blockers. So check for the patient with arthritis of gout, for example. Use of NSAIDs, non-steroidal anti-inflammatory drugs. They may aggravate hypertension. The family history of hypertension is important to ask. So, the family history of diabetic mellitus. Ask the patient whether they have been smoking. The patient on alcohol, patient on high salt intake. So on examination, what should you check? So you need to do history taking. You need to do a physical exam on the patient. Check the BMI of the patient. Check the proper blood pressure measurement as we had discussed earlier. Check fundoscopy, the 4 stages of retinal distraction. Sculpted for the carotid, abdominal, and femoral roots. This is going to give you for the hint for aneurysms. Palpation of the thyroid gland. The causes of secondary hypertension. That's very, very important. You need to examine the heart and the lungs, the cardiorespiratory system. Very important. Check for the abdomen for enlarged kidneys. Check for masses. Abnormal aortic pulsations is very important. Lower extremities for edema and pulses. Neurological assessment is also very, very important. So as a routine laboratory test, you need to check for the EKG. You need to check for the echocardiogram. It's like an ultrasound of the heart. Check for urinalysis. You're going to see the effect of hypertension on the kidneys. Check on blood glucose levels. Patients with unchecked or unmanaged diabetes mellitus, hyperglycemia, they complicate hypertension, or the other way around. You're going to have hypertensive patients complicated with diabetes mellitus. Check on the full blood count. Check on serum potassium. It is going to give you a clue on hyperaldosteronism. Check on high density cholesterol. You do a lipid profile. It's going to give you the high density or the LDLs, the triglycerides. It's going to optimize on other tests such as urinary albumin, excretion, albumin, and creatinine ratio. So the goals of treatment, you need to maintain blood pressure of systolic 140 and diastolic 90 for all patients. Patients with diabetes or renal diseases, the goal is 130/80. So this is because you already have comorbidities. You don't need to have these. So if proteinuria is more than 1 gram per day, control blood pressure to reduce cardiovascular and renal morbidity and mortality. Benefits of treatment, very important. You reduce the complications. The complications are things that we've done. The myocardial infarction, the stroke, the heart failure, and others. Now, what are the best treatments for um, uh, hypertension pharmacologically? So you have the first choice, the second choice, and all that. This one is very important and high yield. It's the mainstream management of hypertension. You can check on the JNC9, the latest version of the Joint Board on Management of Hypertension. It's going to help the Joint National Council for the same. The first choice of drugs, you can use diuretics such as thiazides. You can use beta blockers. You can use inhibitors of angiotensin converting enzyme. You can use beta blockers. They block, not beta block, the angiotensin receptor blockers. They block the angiotensin receptor 1. Calcium channel blockers, you can use them. They're the best and they're the fast choices. In pharmacology, you're going to check with us. You're going to find these medications, how they work, the examples and generations, the side effects, the safety in pregnancies, and all this is best well explained in our lecture in pharmacology. And then the second choice of drugs, you can now use alpha-1 as sympatholytics. They block alpha-1 receptors of sympathetic. Alpha-2 receptor blockers, and then we have direct vasodilators, potassium sparing diuretics, and all these are. And this is on the nephron, and where different antihypertensives work in the renal pharmacology. And when you're going to see our lecture on this, and you find that most of the diuretics, carbonic anhydrase inhibitors, they are going to work so closely on the proximal part of the nephron. And then we have the osmotic diuretics from the proximal convoluted tubule to the descending loop of Henle, and then the ascending, the thick ascending limb of Henle. You're going to find loop diuretics, and then you're going to see thiazides here, and then potassium sparing diuretics. All these we're going to learn more in our pharmacology. And you check on that video, you're gonna find it there. So they are good. You see, beta blockers, we are selective, non-selective. This one we're going to learn more in pharmacology. We talk about calcium channel blockers. We have the phenylalkylamines. These are like verapamil. You have the benzodiazepines. We have the diltiazem. And then we have dihydropyrimidines. We have the first, the second, and the third generation. So we have nifedipine as the most common. We have nicardipine, the second generation. We have amlodipine as the third generation. And then we have the angiotensin converting enzyme receptor blockers. These are very, very important. They're very good in heart failure as well. So we're going to learn more the pharmacology of these medications, how they work, how they cause cough. Usually they have a side effect of cough because they also have high elevation or persistent of bradykinin in the bloodstream. And then finally, we have the effect of these angiotensin converting enzyme inhibitors. The effect, they protect the glomerulus, they improve the salt water balance, they reduce the heart load, they reduce hypertrophy, and the hypertrophied heart regresses. We improve perfusion of the 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 end or the tissues. And then this is the goal as you manage blood pressure. Treatment of secondary hypertension, you need to remove the cause. If it's for the pheochromocytomas, if the connective tissue disorder, you need to check the primary cause of it, and then it resolves spontaneously. So for other crises of hypertension, urgency and emergency, for urgency, you just need to reduce the blood pressure slowly without a lot of anxieties. And then with emergency, you just need to immediately give vasodilators intravenously. So if you don't have an evidence of neurological effect, cardiovascular effect, renal deterioration, and endoscopic or retinopathy, you do not need to rush a lot. You just need to lower your blood pressure slowly while monitoring your patient. But with an emergency, you have target organ failure. You just need to bring the hypertension very quickly into um, control. With the stroke, of course, it worsens as we go. This hypertensive emergency. And then you just need to give IV nitrates. You can give sodium nitrochloride. You can give nitroglycerin. You can give labetalol, esmolol. You can give calcium channel blockers, nicardipine varies, and then you can give enalapril. You can give phentolamine, and then you can give hydralazine. That's very, very important. In urgencies, you do not require medication and immediate reduction, but in emergency, you need. So in urgency, you just need to initiate maintenance treatment without acute loading of oral medication, and then sustain the PP on control. So again, you need to take caution on practice, because initially people used to be given sublingual nifedipine or hydralazine bolus. This must be discouraged. So these expose the patient to unnecessary risk of acute end organ hypoperfusion, because the organs have been used for a high perfusion pressure, and now it's rapid reduction. Now, how can you manage the patient with non-pharmacological therapy? Just need to reduce weight, because you check on the risks. For example, if the patient was obese on diagnosis, you need to reduce the weight. If the patient was a smoker, you just need to stop smoking. If the patient was alcoholic, you need to withdraw from alcoholism and stop if possible. There is physical activity. You need to do minimum of 30 minutes aerobic exercises outside the house. And then you need to restrict sodium intake in diet. And then you need to do what we call the DASH diet. It's called uh, the dietary approaches to stop hypertension. So it's very, very important. And then you need to decrease sedentary time behavior, such as watching television, playing video games, or spending time online. And then you need to control diabetes for diabetic patients. And with this dash that we've spoken about is something you need to take food rich in fruits, vegetables, low fat, and all that. That's very, very important, and high yield. So if you have a question, you just need to drop on the comments below, comment, like, and share. Thank you so much.